go ahead and kick this off. Guys, I don't know if Laurie's going to make it or not, but if she does, we'll just introduce her as she comes in. So I'm going to go ahead and start the webinar. So here we go. Well, hello. I am very excited to pull this group together because we have a topic that, quite frankly, I don't know much of anything about. Is why we decided to do this. It is, in fact, I'll be completely honest with you. Until I got into dealing with the senior world through another company we have, and I ran into people talking about hospice who would go, well, we do hospice and palliative. I had never even heard the word before. So I'm like 1 year of even actually hearing the word. So if I'm that clueless, I'm sure that there's other people out there that are also clueless. So today we are going to talk about understanding what palliative care is. I'm going to go ahead and introduce our panelists here so we can get this thing going. So let's start with Lisa. Lisa, tell me who you are, what your company is, and what your scope of services are that you guys do.
Thank you, and it's a pleasure to be here. I am with Paradigm Health. I am VP of Healthcare Partnerships. We provide palliative care and hospice care to the community, so they're community-based programs. The company is family-owned. We're here locally in Indianapolis, and we provide services to Indianapolis, Marion County, and surrounding donut counties, as well as up in Howard County and up in the Muncie area, Delaware County, Henry County, and so forth.
Oh, very good. Well, thank you. Morgan, tell us who you are, and you're not right here in town, so I'll let you kind of tell, who are you, what is your company, and tell me the scope of what your company does.
Hi, and thanks so much for having us, Jim. I'm Morgan McCall. I am Director of Palliative Care at Intrepid USA. We are a home health, hospice, private duty, and merging into the palliative care realm organization. We have 80 locations across 18 states. So I am not in Indiana, but we do have several locations here in Indiana.
Well, very good. Well, let me ask you a question. Let's just start, and I'm asking this question to both of you, so please fill in as you go. Let's start with the very basics, the very obvious. What in the world is palliative care? So help me understand, help anybody else that's watching this understand what this means.
Well,
go ahead, Morgan.
I always really like to sort of embrace the definition that has been put out, by the experts, right? Which is that palliative care is specialized medical care for people living with a serious illness. And the focus is really on providing patients with relief from the symptoms that they have, whether that's pain, whether that's existential distress, whatever, that may be caused by their condition. And the ultimate goal of palliative care is really to improve quality of life, not just for the patient, but also for the family. And it's provided by an interdisciplinary team. The beauty in palliative care is that palliative clinicians are never necessarily there to take over care of the patient, but really to add an extra layer of support to the patient's routine.
Yeah, and I'll piggyback on what Morgan has shared. Palliative care, what we're finding with palliative care is, especially when you pair it up with home health care, that having both those types of services together, what we're finding is that it's really helping in the decline of hospital readmission rates, which our hospitals are constantly worried about and talking about and trying to figure out, right? So palliative is fabulous in the way that it is a standalone kind of care that really cares for patients that need chronic care, those patients that are COPD, congestive heart failure, cancer. It's patients that have diseases that are not curable, but they're still receiving life-curing treatments. And so that's how palliative helps them and supports them in their treatments. Palliative care looks at a big picture of care. So sometimes when you have home health care, they have a diagnosis and they're working off of one diagnosis, maybe two, you know, but really palliative care is looking at that really big picture of their whole medical history and care. And so that's what we're going to look at. So when you pair it with home health care, though, it becomes even a stronger type of care. Home health care is eventually going to have to discharge a patient off their care, but yet palliative can stay with that patient, still provide care as long as there's a medical need. So that's why it's so fabulous together too. And the reason it can do that is because home health care bills under, you know, if it's Medicare Part A, where palliative is going to bill under Medicare Part B. So palliative care bills like if you went to a specialist, if you went to your cardiologist, if you went to your oncologist, it's going to bill like that. So usually palliative care programs are run by nurse practitioners, at least ours is, and we have 4 different nurse practitioners, but we also have palliative care social workers involved in the care as well. So, I mean, it's just kind of that in between that home health, and you have palliative, and then you have hospice.
Well, that's a good segue. So what is the difference between palliative and hospice?
Well, I mean, palliative is, as I said, palliative care, patients can still have life treatment or curing treatment with palliative care. With hospice, you don't. You don't have life curing treatment with hospice. So kind of palliative care is that segue kind of to hospice. So when they're on palliative care, if we see a decline or a change in their health, then that might be the time to have a different conversation with that patient and their caregivers, and that might be time to have that hospice conversation. And really, we look at palliative as that way to almost get patients on hospice earlier, so they can take advantage of those hospice benefits. And Morgan probably will agree too that, you know, once you get a patient on hospice earlier, their quality of life is better. Their longevity is better. You know, it's just all around what hospice was made to be, not to get on hospice when you pass in 2 days or a week. We'd like to see people on hospice earlier, and palliative can help with that.
It definitely can. And, you know, there's a number of studies that show that, you know, that palliative intervention and really goals of care conversations, simply that, right? Doing advanced care planning earlier for patients can ultimately help them with more timely hospice referral when that's appropriate. But what I'll say is that hospice is appropriate for patients at end of life, right? You know, when we're thinking about the life expectancy being less than 6 months. But when you think about who are we treating in palliative care, those patients with serious illness, and often that could be chronic and progressive illness, as Lisa pointed out, that advanced disease management type patient. And those patients are facing months and years of disease and its treatment, not 6 months, not 6 weeks, right? So who supports them? And that's really where palliative care comes in, right? And I think that it's the goal of the entire palliative care community, really nationwide, globally even, to swim upstream, to capture patients early in their disease process. So a lot of times people ask, and I don't know if this is on your list, Jim, but people say, when is palliative care appropriate? Well, there's really no criteria, right? If you have a serious illness, palliative care is appropriate for you from the time of diagnosis. And again, that goal is to provide an extra layer of support. And as Lisa pointed out, whether that's concurrently with home health or concurrently with all of the other specialists a lot of our patients have more than just one serious or chronic condition. They have multiple conditions, and they're going to that oncologist, they're going to that nephrologist, they're going to that cardiologist. And what's beautiful about those specialists is that they are specialized in that area, and that's typically where their focus is. You know, we're going to address these cardiac meds today, and we're going to talk about how your heart's doing, but are you pulling it together? And then that holistic piece, you know? So that is so important to have palliative care involved really at the beginning, at the time of diagnosis. That way you have that continuity throughout your entire illness journey.
Yeah, and,
So,
and we've had
go ahead, I'm
people
sorry.
graduate off of palliative even.
Pardon me?
Absolutely. I'm so
Yeah.
glad you brought that up,
Yeah.
Lisa. There's a lot in the literature right now, Jim, even about the role of palliative care within survivorship. And I did a talk some years ago, and it was really eye-opening to me because at the end, there was a young girl, maybe 23, 24 years old, who raised her hand, and she was like, I don't know what to say other than that I'm really upset right now because I'm a cancer survivor. I have been battling this cancer for the past 2 or 3 years. She said, none of my physicians ever said anything to me about palliative care. And I could have benefited from this. And I could even benefit from this now as I'm in remission. She said, being cured is almost harder than being sick.
Mhm.
It's like I've lost the support that I had. You know, I'm moving into this area where I'm starting a new career. You know, I'm still dealing with complex issues because my hair hasn't grown back. I have residual pain, constant anxiety that my disease is going to return. Who supports me? And that was, you know, I just thought, oh, wow, I'm going to sit down and let you take the floor. But there's a role for palliative care even in survivorship. So it's in some ways it can be a bridge for people, you know, to help expand that continuum of care. But sometimes they do get better. It doesn't always lead to hospice.
Lisa, you brought up the, they graduate, and that is, something that I've heard through hospice as well, that people graduate out of hospice because they're in less pain, so that they're sleeping better, so that they're eating better, so they're hydrating better, and so all of a sudden they get stronger and they graduate out of hospice. That was news to me about a year ago when I first started learning about that side of things. So here, what is the trigger point? Morgan, you said something as soon as they get the diagnosis. Okay. So what are we talking about? A cancer diagnosis? Are we talking about heart disease diagnosis? What is it what kind of trigger points are there that would all of a sudden make, hey, maybe I ought to call palliative care?
Well, any of those, comorbidity patients probably will qualify for palliative care. If you've been diagnosed with congestive heart failure or COPD, cancer, even dementia, Alzheimer, Parkinson's, MS, some of these diseases that are, as Morgan says, I mean, they're treatable, but they're not curable. You probably will qualify for palliative care. And what I find amazing.
Lisa, you're frozen, I believe. So, Morgan, can you hear me?
Yes, I can.
Okay, all right. Well, I'll wait for Lisa to pop back in.
I might give her a minute, but I can just build upon what she
go right ahead. Yes.
was bringing up. There she is.
Oh, there you are. You're back, Lisa. Go ahead. I'm sorry. We lost you for a while.
Well, and did what part did you hear? In the hospital?
Well, go back to pretty much the beginning, because pretty much after you got started, you froze.
Well, I guess what I'm again, to qualify for palliative, it would be if you have any diseases. Am I frozen again?
No, you're fine.
Okay. You would have any diseases such as COPD, congestive heart failure, cancer, dementia, Alzheimer, MS, Parkinson's, a disease that's treatable but not curable. And that could possibly, qualify you for palliative. And so what I found interesting, and this just happened, I was in one of the heart hospitals in town, and we suggested that a patient go home with palliative care. And the actual cardiologist said to us, why would we do that? They're not critical. And right away you go, oh my gosh, this person has no idea what palliative care is. And you will find, I bet Morgan will tell you this too, how many of the physicians out there have no idea really what palliative care is, or the difference between palliative care and hospice. So there's a lot of education that needs to be done on this subject, a lot.
So true, so true. There was actually, and this could be helpful information. The Center to Advance Palliative Care, they actually did what they called a public opinion research study. They first did it back in 2011, if I'm not mistaken, and they repeated it in 2019. And they independently surveyed, patients and caregivers, also physicians. And what they found, really kind of starting with patients and caregivers, was that 70%, and I can't remember the number, but it was a large sample, and 70% of patients and caregivers reported not being knowledgeable at all about palliative care. And there was actually another 8% that said, we don't really understand what you're asking us. So that kind of speaks to the health literacy of some patients that we serve, right? So when you think about it, really 78% of our patients and caregivers, they don't know what palliative care is. They don't know it's an option. And that's so, so important for the healthcare community, because it's our job, right, as patient advocates, to educate. So to let people know when there is a service that might be available to help and support them. But really what they found in that was so powerful was that when you define palliative care, in the way that they recommend, which was kind of maybe plus or minus a few words, what I shared in the beginning, that definition has a tremendous positive impact on how people feel about palliative care. And the turnaround was that after being explained, this is what palliative care is, 80% said, I would want palliative care for myself or a loved one if we had a serious illness. And what I thought was kind of crucial within that was that when people were asked to identify, what would be the most important thing that you would need to know about palliative care in order to choose it, they said that number one, that palliative care will help relieve suffering. And number two, that palliative care will help provide the best possible quality of life. So I thought that was really powerful outcome from that study. And there was not a big difference between the 2011 and 2019 for patients. Physician knowledge improved, what they sort of described as drastic to be more favorable over that 8-year period, which I was so grateful for. But I must say, I agree with Lisa, we've got a long way to go, because proof tends to be in the pudding. And within that 2019 study, only 28% of physicians reported nearly always talking to their patients with serious illness about palliative care. And I think it was less than maybe 15% reported nearly always referring their patients with serious illness to palliative care. And it's just not enough. It really isn't.
Well, I don't feel as stupid anymore that I didn't know anything about it. So it's like, if a lot of doctors don't know about it, that makes me feel a little bit better. So, yeah.
You're not alone, Jim. You're not alone.
So we have a question come in from that says, is chronic pain diagnosis appropriate for a palliative care?
you want to take that, Lisa, or do you want me to?
If you can, I'll let you go first on that one.
Okay. Yeah, and that's a common question that comes up. I will say that every palliative program is a little bit different in regards to how they handle pain management. Um, I would say that most palliative programs would say that if it's chronic pain management that is related to a serious condition, so let's think maybe a malignancy or cancer, right? That would be appropriate for palliative care to manage. But if it's chronic pain management that's not related to a serious condition, then that would probably be more appropriately served by a pain specialist.
And that's, I'll piggyback on that. That's what I was going to say, is that we would want to know why they're having chronic pain. What's it related to? And if it's going to be related, as Morgan said, to any of these particular diseases, that will make the difference whether they qualify for palliative. If they're just in pain and we don't know why, and there's no diagnosis to follow up that pain, it would be pretty hard to really say if they could, qualify for palliative.
So if we've talked about that you can graduate off and different things like that. So if you can graduate off, is there a time limit that you can be on?
No.
Okay.
We
So as long
always, we say as long as there's a medical need, you can be on palliative.
Okay. So I didn't know how that worked. And you say you want to get on early diagnosis. So now you also mentioned that you're piggybacking this together with like home health. I assume that probably many people would piggyback it with home care as well, like the non-medical care. I would, because of just helping out around the house. I wouldn't be surprised that they weren't, partnered as well at times. So now, as a palliative care, let me ask you this: how can the patient and family benefit from the palliative care? We were talking about all different things, but what things that you're going to augment? Is it I don't know. I'm going to let it go back to you guys. So tell me where does that go into play? Whoever.
Well, a patient will always benefit from extra care, right? Mm-hmm. So if they are in their home, wherever their home may be, and they've got a whole nother set of eyes on them, that's a benefit right off the bat. Palliative care, one thing we have to make sure people understand is, yes, a nurse practitioner comes to your home, but she does not come to your home every day. She's not going to be like home health that comes even 3 times a week. It's going to depend on the initial assessment and care plan and goals of care that are put together when that nurse practitioner comes out the first time. So the nurse practitioner could come out and she may not see that patient again for 3 weeks, 4 weeks, just depending on their needs and what the diagnoses are. But they will have access to a nurse practitioner 24/7. So if they need something, they can make that call and that nurse practitioner will go out. If we see decline in a patient, then the nurse practitioner will be seeing that patient more often. So the benefits are right away, hopefully your nurse practitioner and your team, your clinical team, are developing relationships with that patient and their families and caregivers, so that if there is a decline and there needs to be a change to that care plan, those discussions can be had in maybe a more comfortable way. Not everyone is comfortable having those types of discussions, but palliative care clinicians are comfortable having those discussions. So what it does is it allows the family to have this person that is going to share with them, their clinical sight on what they see happening with this patient, and it might bring up these discussions on whether it's time to make some changes to this care plan. It's time to talk about advanced directives like Morgan brought up. There's a lot of that paperwork that palliative can bring up, because honestly, when a patient gets, might move over to the hospice side of care, it'd be great if all that paperwork's out of the way so the family they just get to enjoy that person and love them and be with them and not have to worry about all that other stuff because it's done. And so, we like to see that happen in that kind of phase of care too. So I hope I answered, but I'll let Morgan answer some more. But I mean, there's so much benefit in having just extra care in the home.
Well, and I think that sort of goes back to, what is palliative care and what is the purpose? And it's that extra layer
Mhm.
of clinical support for the patient and the family. No, maybe not necessarily, someone always in the home or, X, Y, and Z, but depending on what's going on with them, right? So when we're thinking about that patient who has that serious illness, are they dealing with burdensome symptoms? Well, if they are, palliative care clinicians typically are experts in symptom management, right? And I've heard, from a lot of primary care providers, even specialty providers, who might say, "I already do that. I already assess for symptoms. I already assess for X, Y, and Z." It is a little different because when I read notes, I know that my palliative and clinician notes don't always look like maybe a primary clinician's notes or even oncology notes or cardiology notes, right? It's a little bit different assessment, and not to be critical, right? My intention is never to be critical or to patronize the work of every specialty, right? But palliative care is a specialty, right? And there are certain things that they're trained in, that they're experts at, and let's let them do that work, right? I think that we could agree that there are a lot of gaps in our healthcare system, right? And whether that's these uncontrolled symptoms, which might lead to what Lisa was referencing earlier about frequent ED visits, recurrent hospitalizations. Um, the discussions, I think, are huge, right? Most of discussions about what are your goals, what types of treatment would you want or not want, etc. What's important to you. Those conversations typically don't happen enough. They're very late, and maybe in the midst of crisis, right? We're very limited. A lot of people who think that they're addressing advanced care planning needs are really just addressing medical procedures and things of that nature, and not necessarily person-centered questions that really give us information that allows us to align our care plan with the patient's priorities and values. And I don't think that enough can be said about that. It's so, so important.
And we find that most palliative visits, and Morgan, you're probably the same, are longer. I mean, our palliative care nurse practitioners are able to spend a lot more time with a patient than even when you go to a doctor's office. And so that matters. It matters to that care.
I think there was a study that was put out some years back, and they were talking about what is the average time spent in just your typical PCP, primary care provider visit, actual interaction between the patient and either the doctor or advanced practice professional. Any guesses?
7 minutes.
Six.
Huh?
Six
6?
minutes.
I was close.
6 minutes. And I just think, what can you do in 6 minutes? But I kind of reflected on some of my visits, and I thought, I do spend a lot of time there, but face-to-face time with the provider, I don't know. And which I don't want to diminish the work of nurses or therapists, social workers, chaplains, so, so important, and also part of the team. I think that we do tend to lean on the work of our nurse practitioners and physicians because they're the prescribers, right? And a lot of times you do need a prescriber involved, but there's definitely a lot of important work that's done by the entire interdisciplinary team. But you know, the thing is that it really goes back to what have they trained in? What are they prepared to offer and discuss and do? And the fact of the matter is that most clinicians would just say, I've never been trained to have those discussions. I've never been trained to offer that level of symptom management. Because some symptoms are hard to control. And you know, you'll hear, oh, we tried X, Y, and Z, nothing worked. That's just what they do.
Now, this is out of my own ignorance. I'm asking this question, but and I don't know the answer to it at all. But through the conversation here, one of the things I was thinking is both of you have talked about that most of the clients, most of the patients have multiple issues. Okay, they have this thing, that thing, or whatever. Is your person from the palliative care that's dealing with them, are they paying attention to all these? Because you know, the oncologist is giving you, here's what they're doing, and this person is dealing in this area. I know they're dealing with my own family members and trying to help them. You know, if you're not the advocate trying to stay on top of it, you know, they don't seem to pay attention to what the other person's doing. Is the palliative care kind of keeping track of what everybody's doing? I mean, I honestly don't know.
Absolutely. You know, I think that that's the beauty of palliative care, is that the intention is let's pull everything together. You know, I even think about when one of my grandmothers was seriously and critically ill, and maybe a month before she passed, and we're dealing with an acute crisis with her, and I knew at that time that time is short, right? Things are not good. But I will never forget one morning we were at the hospital, and the neurologist came in, and because she had, you know, been getting a good bit of treatment, right, to help correct what was going on with her kidneys, he comes in and the first thing he says is, "Wow, we're looking great today." And my heart just sank because I thought, we don't look great. Hold on. But what he meant was that the kidney function had improved. She had a lot of other things that she was battling that weren't being factored in. And that was very troubling for me, because when after his 6 minutes was up and the room, I had some family members and loved ones who were thinking, Grandma's doing better. But Grandma's not doing better, right? I know what he said, but that's not what he meant, right? So how do we tie everything together and really talk about where we are and prognosis, right? What might we expect in the future? And I would say that anticipatory guidance on disease progression is a big part also of what palliative care might do. You know, a dementia patient might be a really good example. We have this disease. Let's make sure we understand that. You know, what is your understanding? And then let's fill in some of those gaps. And let's also talk about the future, right? As our disease progresses, these aren't decisions you have to make today, but these are some things that you need to start thinking about, you know, as we talk about what are goals, right? What are fears and worries? And where would we draw the line in the sand, right? So that we make sure that we are providing the best care possible that's based on mom, dad, grandma, whoever, based on their priorities and their values.
And I mean, communication is key in all of this. I mean, what we find too on the palliative side is, you know, our nurse practitioners need to be communicating with all the other caregivers that are involved in this care. And as palliative, we don't want to ever come in and take over the care of a patient. We are partnering with other healthcare professionals in the care of a patient. So, you know, communication is key to all of it, for sure.
Absolutely. And you don't want there to be polypharmacy issues, right? If I'm writing orders, I've got another provider writing orders, we all need to be on the same page. And this might be the third or fourth time I've gone back to the definition, but remember,
Mhm.
extra layer of
Mhm.
support.
Well, I think that's important. I was going to say, we have another question here. If someone, especially an elderly person living on their own, has breast cancer and is going through chemo and or radiation, do they fall under palliative care, or don't they, since the intent of the treatments is to cure? So I would think that I'll let you have it.
They
That's a
fall
great
under palliative.
clarification.
Yeah.
Absolutely. Yeah, very much appropriate for palliative care. And I know
Yeah.
that Lisa gave some of the examples of disease processes that we might not expect to cure. And I would say that cancer is an exception to that. And that kind of goes back to walk the illness journey, survivorship, and other instances might be someone who's had an acute stroke, right? They have a need for temporary palliative care involvement or even just consultation, right? And maybe graduate, so to speak. But the illness can be acute or chronic. They can be expected to recover. Again, the point is it a serious illness, and is their quality of life impacted by that illness? If that's true for them and or their caregiver, then palliative care is appropriate.
And that's how we do say, it's chronic care, and when it becomes hospice, it becomes terminal care. Maybe those.
By the way, I have another question that came up. Says, speaking of patients with dementia, is palliative care an appropriate option for someone to stay at home with 24-hour care? Does palliative care provide? I don't think it's going to do 24-hour, but it is appropriate for dementia, I imagine. But I'll let you answer that question.
I think of palliative care as another specialist, right? So, and their specialty is serious and chronic illness, and supplemental care within that. It's like you might have a specialist, a neurologist, right? In dementia care, a palliative care team could help supplement that.
And palliative care is medical care. So sometimes I think people get confused with that 24-hour care. Even in home health and some of the other service lines, people get confused with 24-hour care. A lot of 24-hour care is not medical care, but palliative care is medical care.
Very good. Well, I was going to say one thing, I just got a message here from one of our ones watching, says that this is really informative. Are we recording this? Yes, we absolutely are. It will be on Life's Copilot's Facebook page. It will also be on lifescopilot.com in our resources under our video library. So, so I just want to make sure, yes, you can access this anytime you want it. So we've covered a lot of this, but I'm kind of looking now for like a bullet point, thing, a question, I suppose. What are some of the services that palliative care provides? Just bullet point that for this, because we've been covering.
I think Jim froze on us. Are you still there, Lisa?
I am. Am I frozen? I always feel like I'm freezing.
No, it was Jim's turn,
Okay.
so I'll be next. But since we're still going, I guess we can just kind of jump in on that. And, to let the audience know that really every palliative care program is different. So it is kind of hard to bullet, don't you think, Lisa?
I agree.
But
Yeah.
certainly you could probably do a quick Google search, right, of your area and palliative care, and a number of providers would likely come up, right, to be able to search for providers in your area. And I would encourage you to do that, right, and talk to them about what can you provide, and compare what's going to work best for you and your loved one.
And I guess what we could say is palliative care tends to be pain and symptom management. It's a bigger picture of your health, but that could be a bullet point, I guess, that we could say. But but I agree, every program is different, a little different, and I really think it just depends on the individual that is needing palliative. You
Yes.
know, it's just like in any medical care, um, you have a program, but it's designed for individuals, so it will change based on what a person needs. And so if someone wants more information on palliative care, you know, you can give general information, but really if you're specific on what you really need, you're going to get a lot clearer answers.
Absolutely. And because everybody's medical care plan is different, right? Just like you said. So I think that that intervention is going to be based on the clinical needs of whoever the patient is. Um, but I do think that general pain and symptom management is always integrated, at least a thorough symptom assessment, right? To see where are we. I often tell people that I don't believe that patients don't have any symptoms until I have asked them to rate every symptom.
Mhm.
Because sometimes when people have been living with those chronic conditions, they don't even know to complain anymore, right?
Right.
Because they think, gosh, shortness of breath, I'm short of breath every day.
It
Um,
becomes a norm, I think.
it
Yeah.
becomes the norm, and that's so
Yeah.
unfortunate.
Yeah.
So, I do think it's important to really do a thorough symptom assessment, and certainly that's always included with any palliative care intervention, as well as medication reconciliation. I think a lot of times patients are on medications that maybe interact with each other in not a positive way, or maybe are causing some symptoms that they're experiencing. And certainly counseling, coordination of care, crisis prevention. Lisa, you talked about trying to stay out of the hospital. If that's a goal for the patient, then that's a goal for us, right? What can we do to stay at home? Those goals of care conversations are always included, which would encompass some advanced care planning. So getting healthcare directives in place. For those of you that are watching that might not know what advanced care planning is, that would be talking about your healthcare wishes for the future in advance, right? So sometimes that involves legal documents like a healthcare power of attorney or a living will, orders about what types of treatments you would want or not want if you were to face a serious condition. And then again, anticipatory guidance, right? Thinking about what is the future of my disease going to look like? What are things that I should start thinking about now? And ultimately just ensuring the right care at the right time, that's based on your goals.
And I did see a question come up across my screen from someone asking about how to receive palliative care. Do you need an order from your physician? And you do need an order. An order can be written from a physician or a nurse practitioner, but you need to have an order requesting palliative care. So I just saw that and thought I'd answer.
That's great. Yeah, and certainly, I think again, every program can be different. Most of the time, you will want that order. Some entities, though, if maybe you have someone who hasn't been able to get to the doctor in a while and they're not willing to write orders out that intervention without coming in, and that's a hardship, then it might just be worth talking to the practice about what your other options might be, because sometimes you can just sign consents for billing, and it just depends. It's kind of complicated.
So since Jim's not on here,
I know maybe we could cover a few other high points. I think you brought up early on, at least billing, and that tends to be a question that people have if insurance covers the cost of palliative care. And I guess I would say that a lot of times people will ask, is palliative care a benefit? And currently in in most states, right? In the United States, palliative care is not necessarily, quote, a benefit, but again, it's a specialty. So typically, unless it's integrated into a different service, um, most of the time, if you're getting care from a nurse practitioner or a doctor, they are billing just like you would go to any other doctor. And there's not necessarily a separate bill. So most insurance plans do cover all or part of the cost of palliative care services.
And what we're finding with that billing is if you have a copay that you pay to go see your physician or your specialty physician, you probably could have that same copay for palliative care. Um, and and just like Morgan says, most palliative care services, people are going to, everybody's going to run your insurance, and nobody wants anybody to be financially devastated in any way. So insurances are always run to see what type of benefits are covered. But the majority of palliative kind of tends to be kind of the same as when you go see your physician. So you may have a copay. But then again, like we would run that insurance and try to find that out for you for sure, how much that copay would be.
I also know, and I guess we've touched on this, right, that palliative care usually doesn't take over care of the patient. So a lot of times people ask, can I keep home health? Can I keep my regular doctor? Can I keep, yes, absolutely you can. You do not have to give up anything to receive, palliative care services. And there are a lot of areas that offer palliative care as well. I think that Lisa and I have primarily been talking about community palliative care where patients are at home and maybe receive a home visit or may even go into a clinic. There are, organizations that offer that. But a lot of hospitals have palliative care services. And I think that's really important for patients and families to know that, if you do have to go to the hospital and you think, gosh, we really need that extra layer while we're here, tell them and just ask, do you have a palliative care team here? We would love to meet them and speak with them because it can be a really great help, particularly if you're in a crisis or if you're facing any medical decision points. That is just a crucial element to have.
Should we say goodbye?
I don't think so. I think we are still going. Looks like we're still live here. We might have had 10 minutes. I don't know if Jim was going to wrap us up. Lisa, can you think of any other frequently asked questions that you might get? Oh, we've still got viewers. Thank you, Chris.
Yeah, I see that. I'm here. Thank you.
Are there questions from you guys in the audience here in our last 10 minutes? Things that you want to know about?
There's a couple still here, I see. Yeah, and what Morgan said, I mean, a lot of the hospitals do have outpatient palliative care clinics. But, the good part about the community-based palliative care is sometimes people don't have transportation to outpatient clinics. So it's kind of where companies like ours, like Morgan's, can fill in that gap and come to the home and provide that care. So that's what's important too.
So important. I think most people want to bring palliative care directly to you wherever you call home. And there has been even some telehealth. I know some people are kind of merging into telehealth and prefer that type of involvement. So
we saw a lot of that over COVID, actually.
Mm-hmm. It doesn't feel quite the same. Mm-mm. But certainly an option if that's something that people would prefer. I think that if there aren't other questions, just the high points to sort of recap what we've talked about. If I had to to bullet anything, I would say that palliative care is always individual and based on your needs, right? That it's available at any age and any stage in a serious illness. And even if I know that this is catering to seniors, but even if there are viewers out there who are thinking that you might even have a child, who is struggling with a serious or chronic illness, there are pediatric palliative programs available. I know that my program does not serve pediatrics, and I'm not sure about Lisa's, but any age and any stage in a serious illness, palliative care can be an option to add. And again, you never have to give up anything to add in that palliative support. So you don't have to give up your physician or any other service that you might be receiving from other medical or non-medical care teams. And no treatments, right? So palliative care is delivered concurrently or at the same time as all disease-directed treatments and therapies, and again is best early in your disease process. That way you have that continuity and someone who really walks that illness journey with you.
Mhm. Absolutely, it's added care.
We've got
A
a
great
few.
value of added care.
This discussion is so important. Thank you, Crystal. Thank you, Pamela. Pamela thanks us for our time.
Thank you, everyone.
Yes.
And thank you, Jim, for setting this up. We appreciate it.
Kayla. Thank you, Kayla, for being here. Loretta, thank you so much. Okay, great comments coming in. We appreciate the love.
Yeah. Thank you, everyone.
All right. Well, I guess
Everybody take care and have a great weekend.
It is Friday Eve, isn't it?
I know.
I almost
So
forgot.
happy almost Friday.
All right. Nice meeting you
Nice
and chatting
meeting
with
you,
you,
Morgan.
Lisa. All right. And thank you guys. If there's anything that we can do for you or other questions that you have that you did not want to ask here, I don't hesitate to reach out to us. My email, if anybody is interested, is morgan.mccall@intrepidusa.com. Lisa, do you want to throw out some contact information?
It's Lisa, Lissa. Yes, my mother did that. At plchealth.com. And I think Jim does send our contact information out, but I'm not sure, but I think he does. But again, it's Lisa, Lissa at plchealth.com.
All right. Thank you guys for joining us today and wishing you the best in your health journey. Talk to you soon.
Take care.